He was unable to perform even simple arithmetic calculations. That was his only issue. He was not able to calculate. I gave him some simple maths and 100 minus 10 or 6 plus 6 or 5 plus 5. He was shockingly, he was unable to do that. And this neurological deficit is called acalculia. The topic for today's discussion is the cortex, cerebral cortex, the lobar organization. As always, we will start learning through stories. A 53-year-old man, an owner of a medical store, was apparently normal except for having some hypertension in the past 2 years. He went for his shop one morning and started dispensing medicines, but he was shocked to find out that he was not able to count the money and calculate the bill and unable to return the balance amount. He tried multiple times but was in vain. He drove himself to the hospital and came to my consultation area. On examination, he was looking perfectly fine. He was walking into my room. The blood pressure was very high, 214, 116. There was no motor or sensory deficits or aphasia. He was unable to perform even simple arithmetic calculations. That was his only issue. He was not able to calculate. I gave him some simple maths and 100 minus 10 or 6 plus 6 or 5 plus 5. He was shockingly, he was unable to do that. And this neurological deficit is called acalculia. And then only if you know where this calculation facility is there in the brain, where that faculty is residing, then only can you identify or localize the neurological deficit. On detailed cognitive examination, he had some more. It was not just calculation. He had a phenomena called as anomia. What is anomia? Anomia is difficulty in naming. So it's a naming abnormality is called anomia. He had finger agnosia. What do you mean by finger agnosia? Unable to show the apt fingers. If you want to show all the best, you should show this finger. If you want to accuse a person like this or shout at a person, you use this finger. So like that, you use different fingers for different purposes. That is called finger gnosis. He had finger agnosia. And he also had right-left disorientation. And this syndrome of anomia, acalculia, that is known as the just man syndrome. So the just man syndrome. So only if you have a proper understanding of where these functions are there in the cortex, you will be able to come across such difficult neurological syndromes. So this needs a thorough understanding of the areas responsible for these cortical functions. And this human brain, it is just an awesome organ. It is the most complex machine known till date in the entire universe. The human brain has a grey matter outside and a white matter. So you can see in the picture, the grey matter is outside, the white matter is inside. The grey matter contains all the neurons. So all the neuronal cell bodies will be there in the grey matter. And all the axons will be there in the white matter. So the axons have myelin. And the myelin of all these axons are given by cells called oligodendrocytes. Many students will make confusion with Schwann cells. Schwann cells are for peripheral nerve myelin. So Schwann cells are for peripheral nerves. And the oligodendrocytes are for the central nerves. So in the brain, the myelination is by oligodendrocytes and not by Schwann cells. So the human brain has a grey matter and a white matter. And the grey matter looks less white and greyish because it lacks the myelin. Myelin is all in the white matter. And the neuronal cell bodies are the ones which produce the grey matter. The brain has three parts. You have the cerebrum, the big one, then a smaller little brain called cerebellum, and then you have a brain stem. The cerebrum, it is thrown into multiple folds to accommodate a large surface area. They are called as the gyri and sulci. The superficial area is called grey matter, the deep area is called white matter, and even inside the white matter. So when we tell this is white matter, it is not purely white. Even inside the white matter, some structures are there. For example, this is the internal capsule. Internal capsule is a structure like this. So here you have, near to the internal capsule, you have a grey matter structure here. This is called as the lentiform nucleus. Lentiform nucleus is formed of putamen and globus pallidus. Medial to the internal capsule you have thalamus. Then another medial structure is caudate nucleus. So similarly, caudate, thalamus are all deep grey matter structures seated inside the white matter. So grey matter is there. Even the white matter has some grey matter inside, like thalamus, lentiform nucleus and caudate. Then there is a cerebellum. Cerebellum is otherwise known as little brain. Again, it has a superficial grey matter and a deep white matter. And there also, inside the cerebellum also, there are some nuclei called as the dentate, globose, emboliformis and fastigial. So the cerebellum also has such deep nuclei. And we learned already that the white matter is white because of the myelin sheath, and the myelin sheath is produced by oligodendrocytes that we already mentioned. And now we go to the topic proper, the cerebrum. The cerebrum has a right hemisphere and it has a left hemisphere, and you have a single median sulcus in between that. The central then another sulcus is there. It comes like this. You can see in this picture. This is known as the central sulcus. This is the central sulcus. This central sulcus divides it into a frontal lobe, and this is the parietal lobe. Another fissure is there called as the Sylvian fissure. So the lateral sulcus or the Sylvian fissure, it divides from the frontal and temporal. Then there is another small sulcus here, parieto-occipital. So these are the three sulci which you should always remember. One is the central sulcus, which is this one. This is the lateral sulcus, otherwise called Sylvian fissure. And this is this one. This is called as the parieto-occipital sulcus. So these are the three sulci which you should keep in mind. Now we come to the frontal lobe. In the frontal lobe, you can see this orange color, the rose colored thing. This is the primary motor cortex. This primary motor cortex is in the it is for the motor activities. It is area number 4, and just anterior here you have the premotor and supplementary motor area. So this is the premotor and supplementary motor area. Then another small area here is called as the frontal eye field. So the frontal eye field. What is the importance of frontal eye field? It is for moving the eyes. Then you have the Broca's area. This is the Broca's speech area, area number 44. And the large green colored area is called as the prefrontal cortex. This was premotor, this is prefrontal. So you have a primary motor area, premotor and supplementary motor area. You have the frontal eye field, you have the Broca's area, then the prefrontal area. So let us learn one by one. What is this primary motor cortex? Primary motor cortex is Brodmann area number 4. So we already drew this picture. So this is the temporal lobe. So this is the central sulcus. This is the primary motor area. This much is the primary motor area. Area number 4. Situated just in front of the central sulcus. The central sulcus is the one which divides the frontal from parietal. It's a long sulcus. Here the body is represented. So in the primary motor cortex, the body is represented in an upside down manner. So the face and upper limb comes down and the lower limb comes here in the central part, in the parasagittal area. So here the leg will come, here the upper limb will come. So the body is represented in an upside down manner, and that phenomena is called as the homunculus. So in the next slide we will see what is the homunculus. The way in which the body is represented in the body, in the cortex, is called homunculus. You can see the face comes here. This is the Sylvian field. The tongue and face comes here. The leg is in the medial aspect. So the leg and the bladder. So all the lower part of the body is here and the upper part of the body is lower here. That way of arrangement is called homunculus. Now we come to another area called as the premotor and supplementary motor. You have a primary motor area which we already learned. Then why should you have this premotor, supplementary motor? Why should you have such areas? This is Brodmann's area number 6. This area, this small area is Brodmann area number 6. It is just in front of the primary motor area. It is a motor association area. Why should you have motor association area? Motor association area is for planning and organizing the activity. How you should move your hand, how long you should move the hand, in what pattern you should move your hand. Such planning and organizing the motor activity is done by the premotor area, and the final execution of that activity will be done by primary motor area. Okay. Now you have another area called as the frontal eye field. Frontal eye field is somewhere here, just in front of area number 8. So area number 8 is the frontal eye field. My left brain, left frontal eye field will trigger movements to the right like this. So it helps in conjugate eye movements to the opposite side. So left frontal eye field will be for moving the eyes to the right. My right frontal eye field will be for moving the eyes to the left. So conjugate movement to the opposite side. So suppose there is a problem in frontal eye field, I will not be able to move my eyes to the opposite side. So the lesion, that is what you call as a contralateral gaze palsy. Unable to move both eyes to the opposite side due to a disease in the frontal eye field is what you call as a gaze palsy. Now we come to a very important area in the frontal lobe called as the motor speech area of Broca. This is the motor speech area of Broca, this one. So the frontal eye field came somewhere here, and here you have the Broca. Broca is in the inferior frontal gyrus. Frontal gyrus has some superior frontal gyrus, middle frontal gyrus and inferior frontal. So inferior frontal gyrus has the Broca's area. So what does Broca's area do? It plans, selects and arranges the words which we need to speak. It is best developed in the left brain, dominant hemisphere. Lesions in that area can cause Broca's aphasia. Broca's aphasia is also known by other names like motor aphasia, anterior aphasia, non-fluent aphasia, telegraphic aphasia, etc. Now comes the biggest part of the frontal lobe called as the prefrontal cortex. All the human civilization, all the human intelligence, all the scientific discoveries, all the artists, language, books originated from this area, the prefrontal cortex. Very, very important for the development of human civilization. It is called as the cognitive cortex. All the cognitive functions, majority of cognitive functions are located in the prefrontal area. It is the most anterior area of the frontal cortex. What are the functions? See, very unique functions which are unique for human beings, which separate them from other animals. Personality, judgment, rational thinking and abstract thinking, emotional control, innovative ideas, executive function, all these are in the prefrontal cortex. Then the frontal lobe has an underpart, this underpart beneath. So this is called as the orbitofrontal cortex or the inferior frontal cortex. It's an important area for the natural shyness and inhibitions. Shyness and inhibitions is given by the inferior frontal cortex. The lesions in that area, if you lose that inhibitions and shyness, you become disinhibited. Loss of personal and social inhibitions will occur. So that is the inferior frontal cortex or the orbitofrontal cortex. Very unique area in the medial aspect of the brain called as the paracentral lobule. Here you know that in the median area you have we already have drew this picture. You have the central sulcus here. In the medial aspect of this, the central sulcus will go and wind like this. There is an area like this called as the paracentral lobule. So medial part of the brain, at the end of the central sulcus, you have a cup-shaped area like this, which is partly in the frontal lobe and partly in the parietal lobe. That is called as the paracentral lobule. It is partly frontal, partly parietal. It is an important area for bladder control. Urinary bladder is controlled by the paracentral lobule. Then you have the cingulate gyrus, medial aspect of temporal lobe, beneath the paracentral lobule. The C-shaped gyrus parallel to the corpus callosum. That is also partly frontal, partly parietal. It is part of the limbic system. What is this limbic system? It is that limbic system is important in emotional self-control, emotional response to pain, emotional response to other sensory inputs. So it's an emotional area, the cingulate gyrus. So this cingulate gyrus is important for controlling the emotions. After the frontal lobe, now we jump to the post-central area, behind the central sulcus, the parietal lobe. Here you have, this is the primary somatosensory cortex and this is the sensory association cortex. So then you have the angular, and here you have the angular gyrus and the supramarginal gyrus. So you have the parietal lobe here. So the central sulcus is here. This is the primary sensory area. So this is the primary sensory area. This is the sensory association area. And here the Sylvian fissure is there. Here is the angular gyrus. It is the angular gyrus which was affected in our patient. In the initial case which we studied, we learnt about acalculia, agraphia. There is a phenomena called Gerstmann syndrome. In the Gerstmann syndrome, the site of lesion is in the dominant lobe, usually in the left brain, dominant lobe, and it is this angular gyrus, which is angular gyrus. This is the angular gyrus, which is the culprit lesion in Gerstmann. So these are some of the functions of the parietal lobe. We told about the sensory cortex. The sensory information like touch, pain, temperature, vibration, proprioception, all these are transmitted from the thalamus to the primary sensory cortex. The sensory association cortex will interpret the sensory information. So the primary cortex is for primary understanding of the sensations. The sensory association cortex, what does it do? It will try to think about that sensation. Suppose it is you are getting touched. Who is touching? What sort of a touch it is? Is it being touched by a hand or a wooden substance or a metallic substance or a cloth? So such type of thoughts will be occurring only with the help of the second one, that is a sensory association cortex. You are associating with other prior memories. That is what does it mean. Now our star of the day, angular gyrus and supramarginal gyrus, somewhere here. Our naming, the names which we learn are stored in the angular gyrus. The right-left orientation, the finger gnosis, calculation, all these are done by this angular gyrus. So a lesion leads to this syndrome called as Gerstmann syndrome, which is the diagnosis in our case scenario. Now we go to the temporal lobe. Temporal lobe is situated beneath the Sylvian fissure, beneath the lateral sulcus. This is the lateral sulcus or the Sylvian fissure. The medial temporal lobe is a structure which is actually curved in. So now you are in this picture, you are seeing the lateral temporal lobe. The medial temporal lobe is actually a structure which is curved in like this. So the lateral temporal lobe is more peripheral and closer to the skull. Medial temporal lobe is a medial structure like this. This lateral temporal lobe deep in the Sylvian fissure. Suppose you open the Sylvian fissure like this and look deep into it, then you can find the auditory cortex. And just outside the auditory cortex here, you have the area for understanding the auditory cortex. So auditory cortex will receive the information. And once you receive the information, then the auditory association area, this is called as the Wernicke's area. Wernicke's area is area number 22. That is the area for auditory comprehension, understanding the auditory information. And the medial temporal lobe is a very unique area, the inner part, which we have not seen here, medial area. It contains amygdala, the hippocampus, the parahippocampus, and the piriform cortex. And what are the functions of the medial temporal lobe? The amygdala is very important in emotions, extreme fear, rage, grief. It is by the amygdala. Similarly, the prepiriform and periamygdaloid area, nearby area is important in olfaction. Hippocampus and parahippocampus is important in memory. See the deep structure. So you can see in this picture, this is the lateral temporal lobe and this area is the medial temporal lobe. So here you have this small area where all these important. So loss of memory can occur in lesions of medial temporal lobe. Loss of olfaction can occur in lesions of medial temporal lobe. Emotional changes can occur in medial temporal lobe. And the lateral temporal lobe, we already mentioned, the auditory area and vernix area are in the lateral temporal lobe. Now, last we go to the occipital lobe, the posterior most part of the brain, the occipital lobe. The primary visual cortex is in the tip of the occipital lobe. This is area number 17. You can see that 17. Here you have 18 and here you have 19. These are called as the visual association area. So 18, 19 are the visual association. So the primary information goes to 17. Then you have to assess what I am seeing, where I am seeing. Is it a moving object? How far it is from me? Is it coming towards me or moving away from me? Such sort of associations will be done by the visual association area. So coming back to our medical shop owner story, he had all these lesions like anomia, acalculia, finger agnosia and disorientation. And the site of lesion was in the dominant angular gyrus. It is called as the syndrome of Gerstmann. As this person had an acute onset, we thought that this could be a stroke. And CT brain showed an infarct in the left parietal lobe near the angular gyrus. And what is his present status? He has slowly recovered from the neurological deficit over few weeks to near normalcy without any further recurrence. And now he is on anti-stroke medications like aspirin and he is having a better control of his hypertension. After learning all these different cortical areas, now we will go to few MCQs. MCQ 1. The Anton syndrome is due to a lesion in which lobe? Unless you know what is this Anton syndrome, it will be a difficult thing to answer. Anton syndrome is denial of blindness. Denial of blindness. Because the patient suddenly became blind. Blindness, but even though the person is blind and can't see anything, the person, suppose you ask him, are you able to see everything? The person will tell you, okay, I am very fine. I am able to see everything. No problem at all. And he may walk as if he is a normal person. He will trip onto these things. He will fall from steps and he will have injuries. So that phenomenon is called Anton syndrome. So that problem is in the occipital lobe because it is a visual cortex. Second MCQ, Hemi neglect syndrome. Another syndrome. It's a cortical syndrome. Hemi neglect means you are neglecting one part of your body and the environment, one side. You have the right environment with you, you have the left environment with you, you have the right body, you have the left body. Suppose the person is having a right hemi neglect. Then what happens is the person will not be able to attend to the information from the right side. Right sided visual impulse, right side auditory impulse, right side bodily impulse will not be taken care of. He may not brush the right side of mouth. He may not comb the right part of his hair, head, like that. So that is called as the hemi neglect syndrome. And that is usually seen in lesions of parietal lobe. Because right-left orientation is usually given by parietal lobe. So hemi neglect is a problem with the parietal lobe. Third MCQ, simultagnosia. These are all pretty hard MCQs. Simultagnosia means what? Suppose you are shown a picture. If you are shown a picture of a house, then some trees, then some mountains, sun, road, some kids are there. So suppose you are given a big picture like this and you are asked to tell what it is. He may just tell about a small part of the house. Okay, window. What is the picture? He will tell window. Window is part of it. But he misses the whole picture. So simultagnosia is A problem where the person is able to see a part of the picture, he concentrates only on that part and he misses the total view. He misses the forest for the trees. He just sees one tree. You show the picture of a forest, he will tell tree. He will miss the whole picture of the forest. That is called a simultagnosia. And it is a part of a syndrome called as Balint syndrome. And can you guess which lobe it could be affecting? Balint syndrome is a problem predominantly in the occipital lobe because vision is linked to the occipital lobe. So Balint syndrome is a problem in the occipital lobe and partly parietal. So Balint syndrome is the one where you can have simultagnosia. What are these other syndromes? What is this Weber syndrome? Weber syndrome is a crossed hemiplegia where there is a third nerve palsy on one side and a hemiplegia on the opposite side. And what is this Millard-Gubler syndrome? Another crossed hemiplegia where you can have 6 and 7 palsy on one side and a contralateral hemiplegia. And what is this North-Nagel syndrome? And North-Nagel syndrome is ataxia with third nerve palsy. So that's also a midbrain syndrome. So Balint syndrome is the answer to this question. Thank you.
Docemy.